Meaning of these terms cyanosis and hypoxia? Started? No. Okay. Okay. Now it started. Hello guys, welcome back to PW Meded. Dr. Patil here, and we are continuing our discussions of Reed Harrison's with Dr. Santosh. And today's module we will be discussing about hypoxia and cyanosis. I want all of us to objectively understand the meaning of hypoxia and cyanosis. We should be familiar with some of the important causes for hypoxia and cyanosis. And apart from that, there are some clues which we can get from patient's history, which can lead us to the underlying cause for hypoxia as well as cyanosis. So let us begin first by talking about what is hypoxia. Right? Can anybody tell me what is hypoxia? What do you mean by hypoxia? Manpreet, Nuseba, good evening everyone. Hello. Okay. So what is the meaning of hypoxia? And I have a simple question. Is hypoxia and hypoxemia both are same or different? Right? Technically speaking, both are not same words. Hypoxia refers to decreased availability of oxygen for tissues. Decreased availability of O2 to tissues. Okay. Now I have another important basic physiology question. Why my cells need oxygen? Why do we need oxygen? Manpreet Singh, absolutely right. That is hypoxia, when less oxygen is available to tissues. When less oxygen is there in the blood, we call it as hypoxemia. Right, absolutely right. Now, why tissues need oxygen? What will they do? What my cells will do with oxygen? Right, for conversion of glucose to ATP, right? We need to burn free fatty acids or glucose to generate ATP through oxidative phosphorylation. For that oxidative reaction, we need oxygen, right? So if I'm not giving oxygen to tissues, we will not be able to generate sufficient ATPs, and cells survive by continuously spending ATP. There are a lot of active transports and active processes that is happening. And if I don't give oxygen, I can't generate ATP. All these active processes will shut down and the cell has to die, right? So that is why we need oxygen for cell survival. We need oxygen for synthesis of ATP. Okay. So hypoxia refers to decreased availability of oxygen to tissues, and the term hypoxemia refers to decreased oxygen levels in blood. Decreased oxygen levels in blood. We call it as hypoxemia, right? So if the blood oxygen level is low, that can lead to hypoxia for sure. Hypoxemia always leads to hypoxia, but hypoxia can happen even in the absence of hypoxemia. I may have normal oxygen levels in my blood, still my tissues may be deprived of oxygen, right? Clear? Okay. Now we will understand how to assess a patient for hypoxia. How do we assess? Okay. Best thing is, the most common cause for hypoxia is hypoxemia, and that is why, generally speaking, our assessment begins by assessing the oxygen levels in the blood, right? So please remember, I am making an important statement here. The most common cause for hypoxia is hypoxemia. So if my blood oxygen level is low, my tissues will also be deprived of oxygen. So that is why whenever I suspect that patient is having hypoxia, we check for hypoxemia, right? So how do you check blood oxygen levels? What are the tools that we have for checking the blood oxygen levels? What tools we have? I think all of us are familiar with what we call as SpO2, right? That is one tool. Saturation of oxygen, percentage saturation of hemoglobin with oxygen, SpO2, right? Using pulse oximeter, right? Using pulse oximeter. But is that a very reliable instrument? Is that a reliable instrument? The answer is no. We have seen this in COVID time, right? You have so many memes where people have put the pulse oximeter to the sugarcane or to some non-living object and it still shows saturation, right? This is not a very reliable investigation, but it is a very quick, safe, non-invasive tool to identify. But it can be falsely normal, falsely high, falsely low, right? Particularly, it depends on the pulses, right, reaching the periphery where we are checking the saturation. If I have vasoconstriction, there is no blood flow or reduced blood flow to my fingers, pulse oximetry will show low oxygen levels even when my blood oxygen levels is normal or high, right? So that is not a very good investigation. So then what is the best investigation for recognition of the hypoxemia? I can directly look at the partial pressure of oxygen in the arterial blood, right? How can I look at it? What we call as ABG, we will do ABG. And in the ABG, we will get to know the partial pressure of oxygen, which is usually abbreviated as PaO2, partial pressure of oxygen in the arterial blood. A here refers to arterial blood. PaO2 can be derived using ABG, arterial blood gas analysis. I can do directly puncture the artery, take the sample and check how much is the partial pressure of oxygen. Okay. But what if the patient is already receiving oxygen supplementation? See, many times what happens? Patient starts feeling short of breath, ambulance reaches patient's home, and then the ambulance person or the paramedic will notice that patient is having respiratory distress or maybe hypoxemia. He will put the patient on oxygen. Once I receive the patient in the emergency room, patient is already on oxygen. And because of this high delivery of oxygen, patient's oxygen levels in the blood may be increased. But underneath, there may be hypoxemia because of the disorder. Now, I will be in a critical situation because I can't stop the oxygen. If I stop the oxygen, patient's saturation might drop. SpO2 might drop. Right? But at the same time, I also want to know the degree of hypoxemia. So how can I assess in such situation where patient is already on oxygen and that might have elevated the patient's oxygen levels in the blood? So in such situation, how can I assess? We have something called as PaO2 by FiO2 ratio. PaO2 by FiO2 ratio. Okay. What is FiO2 here? FiO2 refers to fraction of inhaled oxygen. Means now I am breathing the room air, right? And what is the percentage of oxygen in the ambient air or room air or the environment? In chemistry and physics in +2, we have studied that it is around 21%, which I partially disagree because in today's world with so much of pollution, it may be slightly lower, right? And as I ascend up in higher altitudes on mountains and all, it will go on decreasing, right? It will go on decreasing. But roughly speaking, it is around 21%. So when I'm breathing in 21% of oxygen, rest of the air is nitrogen, helium, hydrogen, and other gases, including pollutants. So only 21% oxygen goes into my lungs. With that 21%, I should be able to maintain a saturation of what is a normal SpO2? The normal SpO2 ranges from 94 to 100%. 94 to 100%. I will be able to maintain that when I breathe in 21% oxygen. If you have started me on oxygen supplementation, that means my FiO2 is increased, right? I am breathing higher percentage of oxygen. And then there should be proportionate increase in the PaO2. That is what we try to assess by doing the PaO2 by FiO2 ratio, right? Before understanding that ratio, let me tell you what is the normal PaO2. Normal PaO2 is 80 to 100. Remember, it is the partial pressure and pressure will be expressed as millimeters of mercury. So normal partial pressure of oxygen in the arterial blood is 80 to 100 millimeters of mercury. Okay. When we look at the PaO2 by FiO2 ratio, PaO2 will depend on the FiO2. In a normal condition, as FiO2 goes on increasing, PaO2 should also go on increasing. So the normal ratio of PaO2 by FiO2 is more than 400. It is more than 400. When it is less than 300, we clearly know that patient has got hypoxemia. Can anybody tell me in what setting we use PaO2 by FiO2 ratio for identification of hypoxemia? Because most clinical settings we start with SpO2, if required we look at PaO2. But there are some conditions where we should not rely on these, rather go for PaO2 by FiO2 ratio. Which is that condition? Yes, we use it for the diagnosis of ARDS or acute respiratory distress syndrome, ARDS. After the class, you can go back to your pathology and read a little bit about ARDS and then Google the diagnostic criteria. There is a diagnostic criteria for ARDS called as Berlin criteria. According to Berlin criteria, first thing we need to say that particular patient has got ARDS is to document that there is hypoxia or hypoxemia. And for that definition, we are using the PaO2 by FiO2 ratio. These are the three tools. Among these, PaO2 and PaO2 by FiO2 ratio are most reliable. SpO2 is not very much reliable, but SpO2 being a non-invasive and easy tool, it continues to be used as the common tool for identification of hypoxemia. Okay. Now, we know how to assess for hypoxemia. Hypoxia is most commonly caused by hypoxemia. That's why in clinical practice, mostly we look for hypoxemia. Okay. Now, what can cause hypoxia? The first cause for hypoxia or the most common cause for hypoxia is respiratory disorders, because it is a function of lungs to oxygenate the blood. When there is an issue with that, I will not be able to oxygenate the blood and I can develop hypoxia. What all can go wrong with the respiratory system? Okay. What all can go wrong with the respiratory system? First thing that can go wrong with the respiratory system is, normally what happens, I inhale the air goes into the alveoli, right? Oxygen diffuses into the pulmonary capillaries, and this oxygen is taken through pulmonary veins to the left atrium. From the left atrium, oxygenated blood goes to left ventricle and we eject it to aorta, and through aorta and its branches, it goes to all the body parts or tissues. There, tissues extract oxygen and the deoxygenated blood comes to the right atrium through superior and inferior vena cava. From there, it goes to right ventricle. And this deoxygenated blood coming to right ventricle gets ejected through what we call as pulmonary artery, right? Through pulmonary artery, reaches the capillaries in the alveoli, where it receives the oxygen, goes to the left side of the heart. This cycle goes on. Okay. Now, in what all conditions my blood levels of oxygen can come down? First, if I have a disorder which is affecting the alveoli, right? If there is a disorder which is causing the damage to alveoli. Can anybody tell me disorders which will affect the alveoli? To give you an example, I have filled the alveoli with fluid. Now, obviously, I cannot get the air into the alveoli because it is fluid filled. So, obviously, oxygen cannot diffuse into the capillaries. Right. So, when fluid is filled in the alveoli, we call it as pulmonary edema. Right. It can be because of ARDS or it can be because of cardiac causes. Right. Emphysema. What is emphysema? Emphysema refers to irreversible dilatation of the alveoli. This alveoli can be irreversibly dilated and damaged. Then also, I may not be able to oxygenate. Good. Then, where else we can? Yes. Pneumonia is what? Pneumonia is infection of the alveoli. So, pneumonia. Then, interstitial lung diseases. Interstitium refers to acini or the alveoli plus the connective tissue, right? So, when both of them are affected, alveoli can be affected. So, I may not be able to oxygenate, right? So, those are all examples where respiratory disorders can lead to hypoxemia. As you mentioned, pneumonia, ARDS, okay, and then interstitial lung diseases, right? Emphysema, these all can definitely cause impairment in the alveolar transfer of oxygen to pulmonary capillaries, okay. Apart from that, another condition where I can have this hypoxemia is good amount of air comes into the alveoli. I have good amount of oxygen entering the alveoli. See, when alveoli collapsed, irreversibly dilated and all, I am not able to put good amount of oxygen into the alveoli. Let me say everything is fine. Your tracheal tree, bronchi, everything is fine. Good amount of oxygen comes to alveoli. But I have a problem with the pulmonary artery. There is a clot in the pulmonary artery. If I have a clot in the pulmonary artery, oxygen comes to alveoli, but the blood does not reach this alveoli because there is a clot in the branch of the pulmonary artery. Then what is the outcome? I will not be able to get a good amount of oxygenated blood out because oxygen comes to this alveoli, but blood does not come, right? So this blood is not getting oxygenated. What do we call it as? Alveolar ventilation is normal, but perfusion of this alveoli is reduced. We call it as ventilation perfusion mismatch. And when I have a clot in the pulmonary artery, what should I call it as? Pulmonary embolism, right? Which is not a respiratory disorder. It is a disorder of the blood vessel. So it is a cardiovascular disorder, but we can have that as a contributor to hypoxia, right? So such situations we call it as ventilation perfusion mismatch, like as in case of pulmonary embolism. Okay. Then we can have hypoxia secondary to high altitude. Why we will have hypoxia secondary to high altitude? As we ascend up high in the altitude, the ambient oxygen level starts decreasing, or in other words, patient's FiO2 goes on decreasing. So if I am getting less oxygen into my alveoli, if less oxygen comes into alveoli, right, obviously I will be sending the less amount of oxygen into the blood. So whatever blood that is reaching the left atrium will carry the less amount of oxygen, because my partial pressure of oxygen in the arterial blood is dependent on FiO2. If FiO2 is low, less amount of blood will be there in the oxygen, right? Less amount of blood oxygen will be there in the blood. So hypoxia can also happen because of high altitude. Can anybody tell me what are the adaptive changes that our physiology does? Because see, people live in high altitudes. They don't die because of hypoxia, right? That means physiology does some changes. Suhail, we will be doing that. So this is also part of the symptomatology series itself. So one of the common complaints that we encounter, or it's part of your general physical examination, where you do this pickle. Pickle stands for pallor, icterus, clubbing, cyanosis. So cyanosis is part of the series itself. Right. Body tries to increase the hemoglobin levels and RBC count. Right. How we will increase the hemoglobin levels? Hypoxia triggers erythropoietin production, right? Hypoxia triggers erythropoietin production, and we know that erythropoietin is a stimulant for RBC synthesis and hemoglobin synthesis. So most of the people living in higher altitudes have relatively higher hemoglobin, right? So if the oxygen in the ambient air is less, we will make more hemoglobin and thus build more oxygen in the blood, right? Good. Okay. Then hypoxia can also happen because of left to right shunting. Now, what do I mean by this? Normally, what happens? My right side of the heart handles deoxygenated blood, right? If this is right atrium, right ventricle, this is right atrium, this is right ventricle. So, right side of the heart receives the deoxygenated blood coming from superior and inferior vena cava, and then pumps it to the pulmonary artery, right? So, that takes the deoxygenated blood to lungs, right? And from the lungs, the blood that comes to the left atrium is oxygenated blood, right? So left atrium receives the oxygenated blood, hands it over to the left ventricle, and then we eject this oxygenated blood to aorta, right? So right side of the heart handles the deoxygenated blood or reduced hemoglobin, and left side of the heart handles the oxygenated blood. But what if I have a communication between the right and left side of the heart, as in case you have ASD, right? If you have a atrial septal defect, in that case what happens? Deoxygenated blood coming to the right atrium will go to the left atrium and mix with the oxygenated blood. So what happened now? My left side of the heart is getting some amount of oxygenated blood, some amount of deoxygenated blood. When we mix it, what is the resultant oxygen level? Definitely lower than the normalcy, right? So now this left ventricle will be pumping out blood mixed with oxygenated as well as deoxygenated blood to the tissues. So tissues will start getting less amount of oxygen, right? This is what we call as right to left shunting. It can happen when we have ASD, or it can happen when we have VSD, when the blood moves from right side of the heart to left side of the heart. Okay. Then anemia. Why anemia? Because if everything goes well, I get good amount of oxygen into the alveoli. My pulmonary artery is fine, right? I pump good amount of blood into the pulmonary capillaries. I try to bring that oxygen into the capillaries. But how this oxygen is going to get delivered to tissues? Bound to hemoglobin. If hemoglobin is low, I will not be able to bind that oxygen to to the hemoglobin and deliver it to tissues. So the transportation will be impaired. What is the result? My oxygen levels in the blood will be low because my hemoglobin, the main binding molecule, is low, right? So anemia can also lead to hypoxemia. Okay. Now, these are all conditions where we have hypoxemia leading to hypoxia. But we can also have what is called as circulatory hypoxia. Now, what does it mean? Circulatory hypoxia. That is where, in conditions where you have reduced cardiac output, blood oxygen level is fine. Your SpO2 is 98%, 100%, PO2 is 80% plus, PO2 by FiO2 ratio is more than 400. But amount of this blood itself is not going to tissues because your heart is not able to contract well, or there are other issues. There is reduced cardiac output. So if I am not able to give good amount of blood to the tissues, even if my blood oxygen level is high or normal, but tissues are not getting oxygen, right? So I have hypoxia. How did we define hypoxia? We defined hypoxia as decreased availability of oxygen to tissues, right? Decreased availability of oxygen to tissues. Hypoxemia is decreased oxygen levels in the blood. But sometimes, despite having normal oxygen levels in the blood, if I don't give the blood to tissues, there is decreased availability of oxygen to the tissues, right? That is what happens when there is circulatory hypoxia. This is where you have decreased cardiac output. This decreased cardiac output is leading to decreased tissue perfusion. Decreased tissue perfusion. And when tissues are not getting perfused, they're not getting blood, they're not getting oxygen, right? It doesn't matter how much oxygen is there in the blood. The last one is when tissues are not able to utilize the oxygen. In physiology, you might have studied this situation as either cytological hypoxia or histotoxic hypoxia. Sometimes you also call it a cytotoxic hypoxia. Means here, blood levels of oxygen is fine, your lungs are fine, you are at the sea level, you got good amount of oxygen into alveoli. From that alveoli, the oxygen has gone into your blood. Hemoglobin level is fine. Hemoglobin level is absolutely fine. So it is taking that all oxygen to the tissues, right? Now I give this oxygen to tissues, but tissues are not able to use it. What is the end result? Tissues are deprived of oxygen. In what circumstances tissues will not be able to use oxygen despite giving good amount of oxygen to the tissues? That is what we call as histotoxic hypoxia. Any example where? Yes, if oxygen is not being utilized by the tissues, obviously will not be able to generate ATP. Ultimately, oxygen is required for ATP generation. Right, like example I can quote for improper tissue utilization of oxygen is cyanide poisoning. Right, cyanide poisoning. As you know, cyanide will impair the functioning of electron transport chain and we will not be able to generate ATP. Irrespective of having good blood oxygen levels, we will not be able to generate ATPs because cyanide is impairing your utilization of the oxygen by tissues. So these are all causes for hypoxia. Among these, some are causes for hypoxia, hypoxemia, some are causes only for hypoxia. The circulatory hypoxia and improper utilization of oxygen by tissues are causes for hypoxia. In these patients, hypoxemia need not be there, but anemia, left to right shunting, right to left shunting, high altitude and respiratory disorders, these are the conditions where there is hypoxemia which is leading to hypoxia. Clear? Okay. Now with this backdrop, we will move to the main topic for today, which is cyanosis. Right? Can anybody define what is cyanosis? This is very important because the moment you complete history and start talking about physical examination, you will utter a word saying that, sir, there is no pickle. Many examiners take offense to it because they don't like this acronym pickle. But even if you mention saying that, sir, there is no pallor, icterus, cyanosis, clubbing, you utter the word cyanosis, right? And once you utter the word cyanosis, you should be able to tell at least 5-6 points about it. Without that, your case presentation is not complete. What is cyanosis? Cyan is a word for blue color, right? Cyan is a word for blue color. It is a tint of blue. So cyanosis refers to bluish discoloration. Refers to bluish discoloration of skin and mucous membrane. Bluish discoloration of skin and mucous membrane. In what conditions I can see that bluish discoloration of skin and mucous membranes? For this to happen, right, bluish discoloration of skin and mucous membrane to happen, I need certain amount of deoxygenated or reduced hemoglobin. Remember, the oxygenated hemoglobin is bright red. It is the reduced hemoglobin which appears as blue. So when amount of reduced hemoglobin increases, it gives a blue tint to skin and mucous membrane. And it is dependent on the absolute value. It is not dependent on the relative value. Like, I will just give you an example. What do I mean when I say absolute value of reduced hemoglobin? It is due to increased reduced hemoglobin, reduced or deoxygenated hemoglobin, reduced or deoxygenated hemoglobin. Okay, I'm giving you two scenarios. I have a scenario one, I have a patient A and I have a patient B. Okay, patient A has polycythemia, means his hemoglobin is very high. So let me say that his hemoglobin level is 21 grams per deciliter. Okay, and I have patient B. His hemoglobin level is, let me say, 6 grams per deciliter. He is anemic. Okay, now for this person, the amount of reduced hemoglobin is 25% of it, right? 25% of 21 will be 2.5, another 2.5, right? Roughly around 5.25. So let me say that this patient has got 25% reduced hemoglobin. That becomes 5.25 grams per deciliter. This patient also has 25% of hemoglobin in the reduced hemoglobin form. 25% of 6 will be, can anybody calculate and tell me what will be the 25% of 6? 1/4 of 6, right? 1/4 of 6 will be 1.5. So this patient's reduced hemoglobin will be 1.5 grams per deciliter, right? 1.5 grams per deciliter. Now, whom do you think is likely to appear cyanosed? Who will be likely to appear cyanosed? Nilanjana, yeah, I see. 21, I have seen patients with hemoglobin 21. I have also seen patients with hemoglobin 6. And if you want to take your hemoglobin level to 21, it is possible. All you need to do is start smoking 3 packs of cigarettes per day. Smoke for next 10 years. And I'm very sure you will start touching this, your hemoglobin will start touching this number, which is what we call as secondary erythrocytosis or secondary polycythemia, because chronic smoking causes hypoxia, induces your erythropoietin production, and your hemoglobin level will increase. And people living in high altitudes often have 18, 19 hemoglobin, which is fairly okay for them. Okay, so when I say there is increased reduced hemoglobin, it is an absolute value that is important. When it is more than 4 grams per deciliter, more than 4 grams per deciliter, it gives the bluish tint to the skin. Okay, now this patient, that patient, both have 25% of their hemoglobin in reduced form, but this is a patient who will likely develop cyanosis because his reduced hemoglobin level has crossed more than 4 grams per deciliter. On the other hand, the patient B, his reduced hemoglobin level has not crossed more than 4 grams per deciliter, so that this patient will not have cyanosis. Okay, now whom do you think is more hypoxic? Who is likely to be more hypoxic? It is the patient B, right? Because his hemoglobin is low, his oxygen carrying capacity of the blood is less, but still he will not look bluish. On the other hand, patient A, his oxygen carrying capacity of the hemoglobin is high. He is unlikely to be suffering from hypoxic symptoms, but just because of his high hemoglobin, we have received higher reduced hemoglobin and he will appear cyanosed. Clear? So this is an MCQ that they will ask you, and also during bedside discussion they will ask you what is the minimum amount of reduced hemoglobin required to see cyanosis, right? That would be 4 grams or more than 4 grams. If it is less than that, we will not be able to see cyanosis. Okay. So now we know what is cyanosis. Bluish discoloration of the skin and mucous membrane, which usually happens because of increased reduced hemoglobin levels more than 4 grams per deciliter. Okay. Now when we talk about cyanosis, we generally talk about the peripheral cyanosis and central cyanosis. So we need to understand what is the difference between the two. Okay. Now, is it necessary for me to have hypoxemia to have the cyanosis, which we just agreed that it is not, right? Now, there are various circumstances where despite having good oxygen levels in the blood, right, tissues may be underperfused. If the tissues are underperfused, right, less amount of oxygenated hemoglobin is coming to the tissues, and whatever oxygenated hemoglobin that is coming to the tissues is losing its oxygen because tissues are extracting it, and because tissues are underperfused, it is not quickly returning to the circulation. It is spending time in the tissues itself. So then what will happen? The tissue levels of reduced hemoglobin will increase. So if it is happening at the tissue level, we call it as peripheral cyanosis. And if the oxygen in the blood itself has low, and because of that we are seeing cyanosis, we will call it as central cyanosis, right? So then what is the difference between central and peripheral? Central cyanosis, there is hypoxemia. In peripheral cyanosis, there is decreased tissue perfusion. Because of decreased tissue perfusion, more and more reduced hemoglobin is accumulating inside the tissues. Then how do I differentiate between the two? That is the question, right? Okay, so we will understand the differentiation. What is the mechanism of peripheral cyanosis? Decreased tissue perfusion. Decreased tissue perfusion. What is the mechanism of central cyanosis? Hypoxemia. Hypoxemia is the mechanism behind the central cyanosis. Okay. Now, what site I will see the bluish discoloration? When it comes to peripheral cyanosis, which tissues are likely to get hypoperfused? Is it the core central vital organs of the body, or it is the distal most parts of the body? See, if body has to make a decision that I have only less amount of cardiac output and I have to give it to either major vital organs or I have to give to the distal most parts of the body, which will be compromised? We will compromise the distal parts of the body because we want to keep our kidneys, lungs, liver, brain running, right? We will compromise on the peripheral circulation. So whenever cardiac output decreases, we develop peripheral vasoconstriction. Okay. So the site where I will see the cyanosis is the peripheries. And when I say peripheries, I am primarily referring to hands and feet, right? The cyanosis in peripheral cyanosis will be apparent in hands and feet. That is the location where we will see the cyanosis. But when it comes to central cyanosis, there is hypoxemia. Less amount of oxygen is going to tissues, less amount of oxygen is going to every part of the body, right? So the amount of reduced hemoglobin everywhere is decreased. And because of that, peripheries will definitely show the cyanosis, but we will also see the cyanosis involving the core of the body, which is mainly your mucosa, right? So please remember the site when I say peripheries. In the peripheral cyanosis, only skin is involved. There is no involvement of mucosa. But when it comes to central cyanosis, there will be involvement of skin plus mucosa, because your vital organs or core body is also receiving increased amount of reduced hemoglobin. And when I have involvement of mucosa, right, where should I look for? I should be looking for lips, right, tongue. These are the locations where I will see the cyanosis. I will not see the bluish discoloration of lips and tongue in the peripheral cyanosis, right? This is the most important point I want you to remember, the involvement of mucosa. There is no involvement of mucosa, only skin when it comes to peripheral cyanosis. Central cyanosis, amount of reduced hemoglobin going to every part of the body is reduced, so I will see involvement of mucosa. Okay. Now, another feature that helps me to differentiate whether I have peripheral cyanosis or the central cyanosis is handshake. We say that shake the hand of the patient who is having cyanosis. What information it will give me? It will help me assess whether the peripheries of the body is warm or cold, right? If there is decreased tissue perfusion, what will happen to the temperature of the peripheral body parts? See, why do we have body temperature? Because our cells are burning glucose and generating ATPs. In the process, they are dissipating heat, right? And we are spending ATPs for all the processes where again we are dissipating heat. So tissues are generating heat constantly. That's why our body is warm or it has a temperature. But if there is less blood supply to tissues, there will be less generation of ATPs, less burning of glucose, less generation of heat. So peripheries will become cold. So when we have tissue hypoperfusion, the peripheries will become cold. The skin will be cold. But in central cyanosis, I'm still delivering good amount of blood to tissues, right? So because of that, I will not have such coldness. We will have peripheries which are warm. The peripheries will be warm. Okay. And then last point, if I have still doubt, what I should do? I should try to warm. Okay. So if I warm the peripheries of a patient, how can I warm the peripheries? I can ask him to rub their hands, or I can massage the hands of the patient. After rubbing, right, we are generating heat. And what is the body's response when exposed to heat? Think about it. Like you take your hands and put it in a hot water tub and remove. You take one more hand, put it in ice cold water and remove. Which one will become red? Which one will become red? The hand put in hot water or the hand put in cold water? The hand put in hot water will become red and hand put in cold water will become pale. Why this is happening? Because on exposure to heat, we develop vasodilatation. And on exposure to cold, we develop vasoconstriction, right? So once I warm, I am creating vasodilatation. If the sole reason for me to see cyanosis is decreased tissue perfusion, by causing vasodilatation, I am increasing the tissue perfusion, and then what should happen to cyanosis? It should improve, right? So in peripheral cyanosis, on warming, cyanosis improves or cyanosis decreases. Cyanosis decreases. Okay. Now, even if I warm and cause vasodilatation, if the amount of oxygen in the blood is less, thus amount of reduced hemoglobin in the blood is high, it makes no difference, right? Central cyanosis, the cyanosis will persist. It will not improve on warming. Cyanosis persists. It will not improve on warming, right? So this is how we differentiate between the peripheral and central cyanosis, right? Now, I have one question. What are the causes for central cyanosis and what are the causes for peripheral cyanosis? Can anybody tell me the causes for central and peripheral cyanosis? I've already given you the hint, right? Causes for central cyanosis. What is the principal mechanism? Hypoxemia, right? Reduced amount of oxygen in the blood. So what can decrease the oxygen levels in the blood? We just discussed that, right? We have discussed all the causes for hypoxemia. So when we have respiratory disorders, okay, then when we have right to left shunts in the heart, right to left shunts in the heart, like ASD, VSD and other congenital heart diseases. Okay. Then another condition where I can have central cyanosis is when I have exposure to high altitude where oxygen levels in the blood is decreased. And last and equally important is sometimes abnormal hemoglobin forms. Abnormal hemoglobin forms can also cause central cyanosis. So can anybody name abnormal hemoglobins which are known to cause central cyanosis? Abnormal hemoglobins. Examples we can quote is methemoglobinemia, right? Methemoglobinemia. Okay. Then you have this self-hemoglobinemia, and then carbon monoxide poisoning, right? We call it as hemoglobinemia. The carboxyhemoglobinemia is often considered as pseudocyanosis because there is no increased amount of reduced hemoglobin. It is the carboxyhemoglobin which is giving rise to the discoloration. So these are abnormal hemoglobins. Apart from other causes for hypoxemia, abnormal hemoglobin can also cause central cyanosis. Okay, now what can cause peripheral cyanosis? Causes for peripheral cyanosis. Causes for peripheral cyanosis. And I will also tell you what should be your answer whenever examiners ask you to name causes for central cyanosis. What should be your first answer? According to me, the first answer should be COPD because that is the most common cause for cyanosis in today's practice. And you know that COPD has two components. One of them is called as chronic bronchitis. The other one is called as emphysema, right? Now, between these two, which patient is likely to develop cyanosis? The most common cause or most common respiratory disorder causing cyanosis is COPD. COPD. Now, who is likely to develop cyanosis? Is it emphysema patient or is it patient with the chronic bronchitis? Both are components of COPD. So, remember guys, chronic bronchitis is the irreversible inflammation and destruction of the bronchi. There is bronchoconstriction. Okay. And emphysema is irreversible dilatation and destruction of the alveoli. Okay. Now, who is likely to experience hypoxia? It is a patient with chronic bronchitis, and that is why chronic bronchitis patients are also called as blue bloaters, and emphysema patients are less likely to experience cyanosis, so we call them as pink puffers. So please remember, this is something that usually pops up in your bedside discussions. When you say COPD is a cause for cyanosis, you should specifically mention chronic bronchitis, and patients with chronic bronchitis are often referred to as blue bloaters. They are also known as blue bloaters because they are cyanosed. The word blue comes here because these patients are cyanosed. We call them as blue bloaters. Okay. Sumit Deshmukh, I think they have shared it on the PW Meded Telegram. Just look into the links and you will be able to find it. Okay. Now, coming to the causes for peripheral cyanosis. The first thing I want you to mention whenever an examiner asks you to name the causes for peripheral cyanosis is they're called as blue bloaters. The reason they're called as blue bloaters is patients with chronic bronchitis have a tendency to develop right heart failure. And once they develop right heart failure, I'll also tell you why they develop right heart failure. They're chronically hypoxemic, right? So chronic hypoxemia causes pulmonary vasoconstriction. And if I cause pulmonary vasoconstriction, I think we had done this image of circulation, right? Okay, so patients with chronic hypoxia, they will have pulmonary vasoconstriction. So these capillaries are all constricted. And if these are constricted, there will be resistance created to the flow of blood from right ventricle to pulmonary artery because the pulmonary artery pressure will be high. This is what we call as pulmonary hypertension. And if pulmonary hypertension occurs, right ventricle will do a lot of work and eventually fail. So lung disorders can lead to right ventricular failure or right heart failure. And the most common lung disorder leading to right heart failure is COPD itself, right? Why it is happening? Because of persistent hypoxia, there is vasoconstriction of the pulmonary capillaries. Okay. And once I develop right heart failure, what will happen? I will start developing the ascites, pedal edema, right? So these people appear bloated. That's why they're called as bloaters. And because they appear cyanosed, we call it as blue bloaters. Cyanosis with bloating with fluid or edema. So we call it as blue bloaters. Yeah, right heart failure happens because of the pulmonary vasoconstriction. Similarly, if I have like ILD or interstitial lung disease, the interstitium will be distorted. Again, it will create obstruction to the flow of blood from pulmonary artery to capillaries. The pressure in the pulmonary artery increases, which will impact the right heart function. Okay. First answer that you should mention whenever someone asks you the causes for peripheral cyanosis is the peripheral vasoconstriction. And in what condition peripheral vasoconstriction will happen? On exposure to cold, right? On exposure to cold. So on exposure to cold, if I develop peripheral vasoconstriction, my limbs will appear pale. What we call this condition as? Right, we call it as Raynaud's phenomenon. And there are two things. There can be primary Raynaud's disease and secondary Raynaud's disease. So primary is where just because of the exposure to cold, there is vasoconstriction and I'm developing paler, and the tissues are not now vasoconstriction, reduced tissue perfusion. So amount of deoxygenated hemoglobin that is there in the tissues is not getting cleared. It accumulates in the tissues and the limb might appear cyanosed, right? The peripheries might appear cyanosed. Another situation that can happen is these blood vessels are diseased. They are occluded. So in that case, again, tissue perfusion will be reduced and I can develop cyanosis. So if the blood vessels are occluded and that is leading to reduced tissue perfusion, we will call it as secondary Raynaud's phenomenon. So first one is Raynaud's disease. Raynaud's disease. Raynaud's disease is the condition where there is exaggerated physiological response to cold. Exaggerated physiological response to cold. Normally when exposed to cold, we should develop the vasoconstriction. Here that is too much exaggerated, giving rise to tissue hypoperfusion, pallor and cyanosis, right? The phenomenon is called as Raynaud's phenomenon. The disease is called as Raynaud's disease. And then we have this secondary Raynaud's phenomenon. Secondary Raynaud's phenomenon where it is not an exaggerated physiological response. There is a problem with the blood vessels. Can anybody tell me where we get secondary Raynaud's phenomenon? Where we get secondary Raynaud's phenomenon? One example. I will give you a clue. It is a rheumatological disorder. It's a rheumatological disorder. And we use Raynaud's phenomenon in its diagnostic criteria. So which disorder I'm talking about? Rheumatoid arthritis, we can see, but not very common. We can see, I agree. But when you hear Raynaud's phenomenon, this disease should come to your mind. We call the disease as either scleroderma or systemic sclerosis. In those patients, actually this decreased tissue perfusion eventually will lead to necrosis and atrophy of the tissues, and the fingers will start becoming smaller and smaller. That's why we call it as scleroderma, right? So scleroderma or systemic sclerosis is one common cause for secondary Raynaud's phenomenon. The third condition where I can see the peripheral cyanosis is if my cardiac output itself is reduced, right? In that case, what will happen? Less amount of blood is coming to the tissues, tissue hypoperfusion, and I will develop cyanosis. Okay, in what condition I can develop reduced cardiac output? Decreased cardiac output. Decreased cardiac output can happen when I have shock, right? As in patients with shock. Patients with shock, the cardiac output can be decreased. Less amount of oxygenated blood is coming to the tissues. So, Tapa Samantha, scleroderma is a rheumatological disorder, just like how you have rheumatoid arthritis or SLA. It is one more disorder which predominantly affects the skin and blood vessels. So, what happens there? For some unknown reason, these patients' blood vessels start becoming narrow. And because of the narrow, mainly the small distal blood vessels in your hands and feet. Because of that, there is reduced blood supply to the tissues. And because there is reduced blood supply to the tissues, these people experience Raynaud's phenomenon. And because there is reduced blood supply to the tissues, skins will start developing, the skin of the hands, right, the fingertips, start developing small necrotic or ischemic ulcers. Eventually, ulcers heal with fibrosis. So, skin starts becoming tighter and tighter. And as it becomes tighter and tighter, tightness of the skin is what we call as scleroderma. Derma means skin, sclero is fibrosis or tightness. So, these patients have tightness of the skin. Okay. So, when we have shock, right, hypovolemic shock or cardiogenic shock, in those cases, cardiac output will be reduced. So, less blood goes to the tissues. And because of that, we can have peripheral cyanosis, right? How do I identify whether patient has got peripheral or central cyanosis? Rub the peripheries. If warmth improves the cyanosis, it is peripheral cyanosis. If warmth does not increase the cyanosis, it is mostly central cyanosis. Yes, heart failure can also cause the decrease in cardiac output. So, We can go on listing it. Why am I stressing more on the primary mechanisms? Once we know the mechanisms, we can make a list of conditions where we can see them, right? So heart failure, hypertrophic obstructive cardiomyopathy, aortic stenosis, mitral stenosis, in all these conditions we can have reduced cardiac output. Okay, so these are the causes for peripheral cyanosis. You should know the causes for central, you should know the causes for peripheral, and you should know how to differentiate between central and peripheral cyanosis. Okay, so here we have some images of patients with cyanosis. You can see a patient with the peripheral cyanosis here, right? His hands are showing the bluish discoloration. If you see here and here, you can notice that there is bluish discoloration. Okay, and in this patient, you can see bluish discoloration of the lips and the tongue. That is the mucous membrane, right? So the bluish discoloration of mucous membrane indicates that patient has got central cyanosis. Central cyanosis, skin and mucous membrane. Peripheral cyanosis, only the skin of the peripheral body parts. Okay. Now that we know the causes for the central and peripheral cyanosis, the last thing we need to know is, can I identify the underlying cause for cyanosis from the history or examination findings? Because the moment you utter the word, sir, this patient has cyanosis, the first thing examiner will ask you is, what do you mean by cyanosis? You will say bluish discoloration. Then he will ask you, when do we see bluish discoloration? You will say reduced hemoglobin level more than 4 grams per deciliter causes it. Then he will ask you, what is the difference between central and peripheral? Tell me 1 or 2 causes for central, tell me 1 or 2 causes for peripheral cyanosis, right? After that, one last question which examiner will ask you is, what do you think is the cause for cyanosis in this patient? And if you're able to answer that, that means you have scored brownie points. If you come till this point in discussion, then that means you already passed. But if you can answer this last question, what do you think is the reason for cyanosis in this patient? If you're able to answer that, you will get brownie points or extra points. So in addition to passing, you will get extra marks. Okay. So then, how can I identify the cause for cyanosis in a particular person? First thing, yes, by differentiating central versus peripheral, I will already have narrowed down my differential diagnosis. But we also get some clues from the history. I have listed only 2 important points that as an undergraduate student you should know. The first one is presence of cyanosis from birth. If the patient's family members say that, sir, this kid has been looking bluish from the day of birth itself, what should come to your mind? So cyanosis from birth indicates mainly the congenital heart diseases, right? Congenital heart diseases with right to left shunt, where the deoxygenated blood is getting mixed with oxygenated blood, and thus the amount of the deoxygenated blood going to tissues is increased, right? Congenital heart diseases. Nilanjan, methemoglobinemia can be an inherited disorder or it can also be acquired. It need not always be inherited. So you can see it appear later in the life. If it is inherited, it might be there at the time of birth. Second thing is presence of cyanosis with the clubbing of the fingers. See, that is why when we do this case presentation, right, we say pickle. Cyanosis and clubbing, we have clubbed together. Because there are conditions where we can have, see, over time when you have this, hey, okay, I will tell you. Let me say this is my left atrium. This is right atrium and left atrium. Between these 2 chambers, we have a interatrial septum, which separates the right and left atrium. Now, if I have a small hole in this atrium, right, we will call it as atrial septal defect. I'm just giving you one example. This can happen also at the level of the ventricle. So this defect we call it as atrial septal defect. This is our AST. Okay. Now, physics says fluid moves from one chamber to other chamber with respect to pressure gradient. If pressure in the right atrium is more than the left atrium, the blood from right atrium will move to left atrium. If the pressure in the left atrium is more than the right atrium, blood from left atrium will move to right atrium. Normally, which side has higher pressure, right side or left side? It is the left side which has higher pressure. If you are in first year MBBS or second year, you might remember the anatomy dissection and you might have seen the heart, right? The heart is slightly more muscular on the left side than the right side. Left ventricle, left atria are more thicker than the right ventricle, right atria. And being more muscular, they will be able to generate more force of contraction. And thus, pressure on the left side of the heart is more than the pressure on the right side of the heart. So in normal condition, even if I develop an ASD, mostly blood will move from left atrium to right atrium, which is not a big deal because some amount of my oxygenated blood is going to mix with the deoxygenated blood, but whatever blood comes to right atrium goes to right ventricle. From the right ventricle, this deoxygenated blood along with the oxygenated blood will go to lungs, get oxygenated and come to left atrium. Not a big deal. The problem is when inverse of this happens, once there is a reversal of this shunt, when the blood moves from deoxygenated blood moves from right atrium to left atrium, now I am mixing the oxygenated and deoxygenated blood, and this mixed blood is one that is going to the tissues, right? When will that happen in a patient with ASD? Most patients with ASD will have left to right shunt. Oxygenated blood from left atrium will be mixing with deoxygenated blood in the right atrium because pressure in the left atrium is more than the pressure in the right atrium. But if more and more amount of blood starts coming to right atrium, thus more and more amount of blood starts coming to right ventricle, right? Whenever a muscle handles more volume of blood, it grows, right? Why people go to gym? Because they do a lot of work, and by doing more work, they build muscles. So if more and more blood comes to the right atrium because of this shunt and thus more to the right ventricle, they will start becoming bulkier, right? So as they start becoming bulkier, when they become bulkier, we will call it as hypertrophy. So right ventricle will develop hypertrophy, right atrium will develop hypertrophy. Once they become hypertrophied, their muscle mass some point of time will become more than the muscle mass of the left side of the heart. In that case, they will be able to generate more force of contraction than the left side of the heart. So in that case, my right atrial pressure will become more than the left atrial pressure. In that case, my deoxygenated blood will now start moving into left atrium from right atrium. This is what we call as shunt reversal. This is where oxygenated, deoxygenated, mixed blood is going to tissues, giving rise to cyanosis, right? Okay. Now, in what conditions we get cyanosis and clubbing? So if you have a patient with cyanosis and clubbing, you can think of only two disorders. The first one is congenital heart diseases. Congenital heart diseases with right to left shunt. Heart diseases with right to left shunt. Blood is moving from right side of the heart to left side. And the second one is when you have suppurative pleuropulmonary diseases. When you have suppurative pleuropulmonary diseases. Now, what do I mean by suppurative pleuropulmonary diseases? When you have long-standing pus-forming infections of the lungs. In what condition I can have long-standing pus-forming in the lung? Suppurative lung disorders. I want you to remember two examples where you can have suppurative lung disorders. One of them is chronic lung abscess. Chronic lung abscess. There is an abscess in the lungs which is infected, putrid, and that part of the lung where there is abscess is not participating in gas exchange. So I have hypoxia or hypoxemia that has resulted in cyanosis, and this suppuration will also result in clubbing. Right? The second condition I want you to remember is when you have bronchiectasis. Bronchiectasis. What is bronchiectasis? Obviously, the name itself is suggesting bronchi, right? So we defined emphysema as irreversible dilatation of alveoli. Similarly, if I irreversibly dilate the bronchial tree, right? Bronchi become irreversibly dilated. We call it as bronchiectasis, where again recurrent infections and pus formation can happen. These patients can also develop clubbing. So whenever you have a patient with cyanosis and clubbing, think of either congenital heart disease with right to left shunt or suppurative lung disorders like lung abscess or bronchiectasis. Right? These are additional potential clues that we should be familiar with. Okay, so that's all we had for today. What we have learned today, we have understood what is hypoxia, what is hypoxemia, how to assess for hypoxemia, looking at SpO2, looking at PaO2, and looking at PaO2 by FiO2 ratio. We have understood the causes for hypoxemia, and then we have understood the causes for cyanosis, peripheral as well as central, and we know how to differentiate between central and peripheral cyanosis. Okay, and then how to recognize underlying cause, looking at central versus peripheral, and some additional clues, right? Cyanosis present from birth is congenital heart disease. Cyanosis with clubbing is either congenital heart disease or suppurative lung disorders. So that's all I had it for today from the Read Harrison with Dr. Santosh series. I unfortunately could not bring in the pages of Harrison because on a smart board it is a bit difficult to display the white sheets, but I will make it a point to include those pages from Harrison on the cyanosis in the upcoming notes discussion, where I will be using my iPad for teaching, and we will do some MCQs based on this. This is an important topic from which a lot of INI CT and NEET PG MCQs come apart from your bedside discussion. And as some of you suggested, the future plan for this series is we will have this approach topic from Harrison, but at the same time, every discussion we will have one sign or one examination finding, like pallor, how to assess pallor, where we get the pallor, and what questions that will be asked from the examiners. In another session, we will take the icterus. So we'll go on addressing all the bedside signs that is required for us from Harrison as well as general medicine. So for today, that's it, guys. I will share the notes it on the Telegram, and please stay in touch. And as you mentioned, if you have any specific queries or request, you can definitely put it on the comment section, or you can ping it to me on the Telegram, and I will make it a point to address them in the subsequent session. So Tapas Samantha, yes, absolutely, I agree. We will be definitely bringing in more clinical questions. Thank you all, guys, and have a good night. See you soon. Thank you.